First, a special documentary report on the topic of cancer pain. Next week, the President's Cancer Panel will hold a public hearing at the University of Wisconsin-Madison, and there is a continual search for new cancer treatments, for cures. But while the search for a cure continues, cancer patients sometimes suffer needless pain. They suffer not because pain relief is impossible, but because we are sometimes more focused on that elusive cure than on compassion. Tonight's documentary report, Prescription for Compassion, produced and reported by Joanne Garrett.
Illness, wrote author Susan Sontag, is the night side of life. Everyone born holds dual citizenship in the kingdom of the well and the kingdom of the sick. Although we all prefer to use only the good passport, sooner or later, each of us is obliged, at least for a spell, to identify ourselves as citizens of that other place. Sontag wrote those words after a battle with cancer. In this world, 1 out of every 10 people will face a similar struggle. 1 out of every 10 people will suffer from cancer, and at least 70 to 80% of those people will suffer from pain, often excruciating, always unnecessary. What follows are directions for a more merciful passage. What follows is a prescription for compassion.
There are more than 3.5 million cancer patients every day with severe to moderate pain, and there is utterly little done against it.
There was times when if you could buy street drugs, you probably would. And you don't know the quality, the dosage or anything, but you are up against the wall. There's only one other way out, and that's suicide.
You owe it to these patients to at least provide them with relief of the symptoms of cancer. You owe it to them to enable them to die with as much dignity as possible, to die free of pain.
A Sunday morning at Christ the King Baptist Church in Milwaukee, Wisconsin. The parishioners have gathered together to give thanks and celebrate life. To celebrate life with music and prayer. Singing alto in the choir is Loretta Gersey, a woman in her 50s, mother to 6 children. 5 years ago, Gersey received a diagnosis that took her from that kingdom of the well to the kingdom of the sick, a common and dreaded diagnosis, a diagnosis of cancer.
About a month before I was supposed to go for my checkup, yearly checkup, I felt there was that lump, I said, oh no. That's what I did. I had a modified radical mastectomy. 5 years after that is when I started feeling, something around my neck area and around that area. So I went to the doctor, and that's what it was recurrence of the breast cancer.
God the Father of our Lord and Savior, Jesus Christ. Yeah.
The cancer had reappeared in Mrs. Gersey's lymph nodes. This time, she had chemotherapy to treat the disease, and this time, Gersey had a symptom often associated with cancer. She had pain, severe pain.
Some lost soul is calling on
It was just sharp. It just felt like it was something there, you know, twisting and turning inside of you, you know, if you could get that out of you, you'd be fine.
Sometimes through the storm, sometimes through the rain.
That's how I felt. I said, this is how I have to go on with this treatment, you know. I'd rather not take it. I just rather stop and just let things go. If you know, if it was my time, it's my time. I just didn't want to go on with it anymore.
I feel like pressing my way. Oh, I feel like
Sharp, sharp pain.
Pain, wrote Dr. Marcia Angel, is soul-destroying. It can cut the connections to the world of the well, isolating the patient away from friends, apart from family.
So what you gonna do? You can't eat, or you going here and you gonna play basketball?
Loretta Gersey was lucky. Her doctor quickly prescribed drugs for her pain, including the narcotic oral morphine. Her pain disappeared. After many months of chemotherapy, Loretta Gersey has been given a clean slate, no trace of cancer. Now she must, once again, mark off months and years to be confident of a cure. This is Spooner, Wisconsin, a small town in the northern part of the state, home for Catherine Nelson. Mrs. Nelson is a widow. Her husband, Chester, died of colorectal cancer several years ago. Like many patients, when Chester Nelson heard the diagnosis of cancer, he had an expectation of pain. Unremitting and unrelieved, his expectation was accurate.
That he would wake up in the night approximately every 2 hours crying out with pain. I would get up and we would sit and visit, and he would take what meds he had for pain control and hopefully go back to sleep. He said to me, I don't mind dying or being dead. I have no fear. But he said, I know what I have to go through to die.
So there's a definite cancer mythology. In fact, one of the major textbooks of oncology has a whole chapter that deals with issues of mythology, cancer as an allegory in society, and what it means to people to have cancer. And the issue of pain is all caught up in that.
Dr. David Wiseman is an oncologist specializing in pain, part of the staff of the Medical College of Wisconsin in Milwaukee.
He's feeling better since he came here. In relation with his pain was.
Wiseman chairs a weekly meeting on cancer pain for interested medical residents. When he was a resident, Wiseman's first hospital admission was a cancer patient who was suicidal because of pain.
Your major problem has been with abdominal pain recently?
The pain group visits cancer patient Juan Colon. Medical professionals might term this visit palliative. It means to comfort without curing, to treat the symptoms of the disease, to treat the pain. Others in this hospital may provide a healing touch. The goal of this group is to take away the hurt.
I get tired so easy.
You do. Does the pain keep you from moving around at all?
Yeah.
It does. As time has gone on, we become more technologically advanced. We become more interested in diagnosis and treating towards cure. Some of the palliative aspects of treatment have perhaps fallen behind.
Nuts, no.
Tying knots.
Like cramps?
Pain is something that often gets left behind.
There is a coalition of medical personnel in Wisconsin that has taken up the issue of cancer pain, the Wisconsin Initiative for Cancer Pain Management. It's a coalition that has made its mark in large part by conversation, by establishing connections to exchange information between medical professionals, with patients, educating in classrooms and press conferences, all to spread the word that cancer pain relief is possible. World Health Organizations recommend a simple prescription, the right drugs in the right dose at the right time, on schedule, rather than making the patient request them.
Types of chemo, right? The World Health Organization has estimated that with current technologies, we can control 80 to 90% of all pain. So it's not like we have to find some new drug. It's not like we have to invent some new technique to control pain. The techniques are there. What we need to do is learn how to use them better. Use what we've got.
What medicine has, what WHO, the World Health Organization, recommends for cancer pain relief is a simple three-step ladder of medication. It starts with mild analgesics, such as aspirin. Step 2 consists of stronger painkillers, the mild narcotics, such as codeine. Step 3 concludes with the strong narcotics, drugs such as oral morphine.
Some patients expect cancer to be painful. They just expect it, and therefore put up with needless pain.
Dr. Charles Cleland is a pain specialist at the University of Wisconsin in Madison. In a 1985 study, Cleland surveyed patients and the general public about their attitudes toward cancer and pain. Nearly 79% of those surveyed agreed with this statement. Cancer patients usually die a painful death. 18%, nearly 1 in 5, agreed that they might put off treatment or avoid it altogether because of fears that the treatment would be painful. But patient attitudes are only part of the problem.
The whole problem of why we're in this mess to begin with, from the physician standpoint, is that physicians are often reluctant to prescribe pain medication, often reluctant to prescribe powerful pain medication.
University of Wisconsin pharmacy professor Dr. June Dahl.
Some doctors and nurses can be horrified when they hear that a patient is receiving 100 to 200 milligrams of morphine. That sounds just awful.
And we've had patients who are on extraordinary doses of analgesics that if I gave to you or me would put you asleep for a couple days. These patients will sit up in bed doing crossword puzzles.
Strong drugs for strong pain, the sort of drugs that can bring up fears of addiction, fears that, according to the initiative, are unfounded.
Physical dependence is not psychological addiction, and physical dependence is easily reversed.
There is virtually no instance of primary addiction in a patient receiving narcotic analgesics unless that patient has a prior history of drug abuse. So it's just not an issue.
What is an issue is that fear of addiction, a fear that has infected health professionals, patients, and their families. Rick Heydrich, a pain researcher at the University of Wisconsin and a member of the Wisconsin Initiative.
We have to change. These medications are for these people. I mean, that's what they're for, and these people should have access to them in the amount that they need to control their pain. I mean, that's the right of the patient.
After months of suffering and frustration, just 4 months before he died, Catherine Nelson was finally able to locate a doctor who was willing to prescribe oral morphine for her husband.
The morning after he got this first prescription, that was the first night he slept through for many, many months. He said, I could just weep. I had one good night's sleep.
The first day dedicated to the freedom of cancer pain and relief of cancer pain.
December 1987, a news conference in Madison, Wisconsin. Dr. Jan Sternswert, director of the World Health Organization, WHO's Cancer Unit, announces another connection in the battle against cancer pain, the designation of the University of Wisconsin in Madison as a WHO collaborating center for cancer pain management. The center's role is to measure pain relief efforts, both here and abroad.
You can then go in and introduce good pain management and show what the difference is. If you can demonstrate a difference, or if you can identify the problems when you don't show a difference, then you have some tools that you can use to affect policy.
Every year, nearly 4.5 million people die of cancer. Every day, nearly 3.5 million suffer from pain. The problem, in part, is the policy of most governments toward the drugs necessary for pain relief. These are the countries that allow for the use of oral morphine: the United States, Canada, Australia, New Zealand, and most of the countries in Northern Europe. Those countries, those continents colored in blue, do not. Dr. Stearns'
Because most cancers, that's half of mankind's cancers, are in developing countries. And 3/4 of them, if not more, are at time of diagnosis incurable and will die of their disease. So the only pragmatic, humane, and realistic you can do for many years to come is pain relief.
But how to best provide pain relief across cultures, in different countries? Thousands of miles from Wisconsin, another country has tackled the problem of cancer pain. The country is India. Some describe it as a subcontinent rather than a country. It is that vast, that varied. India has been an independent nation for just under 50 years, but its culture and history stretch back for 5,000. It is home to 1/6 of the world's population. Home also to 500,000 new cases of cancer each year. And it is a country like most in which oral morphine is illegal. If this country of some 880 million people is able to create a model for cancer pain relief, to convince its government of the necessity for oral morphine, other countries would have an example to emulate, an example difficult to ignore. How to deliver pain relief to India's people? This country is known for its teeming cities. It is not so well known that 80% of India's population lives in rural areas, small villages, such as this one, the village of Ode, some 300 kilometers north of Bombay, in the state of Gujarat. Ode, population 2,500. At first glance, it seems like a town untouched by time, but a closer look shows a curious tug between old and new. Crows perched on power lines, motorcycles mixing with hand-drawn carts. Each Sunday, the villagers gather to celebrate a weekly ritual to honor the Hindu goddess Melody, patron of farmers and shepherds, the profession for most in Ode. With a circle of singing and dancing, incense and rhythm, the villagers have gathered to give thanks and celebrate life with music and prayer. To celebrate life, a life that for most is lived in towns like Ode. Any solution to the problem of cancer pain in India must include these villages. These villages that are far from cities with hospitals and that specialized care. The outpatient waiting area in one such hospital, Tata Memorial Hospital and Cancer Research Institute in Bombay. It is one of the largest cancer facilities in the world. Patients and their families come from across the country at a rate of 1,000 a day to take advantage of an impressive array of technology, to find a cure for their cancer, to find relief from their pain. Dr. Shushila Shah is the director of the hospital's pain clinic. She is also president of the Indian Society for the Study of Pain, a group that in 4 years has grown to some 500 members.
She has got a pain here on this side, and it's going down to the leg.
Here in this facility, filled with the most current of technologies, Shaw supervises the injection by 2 medical residents of a very old drug, morphine, for a patient suffering from cervical cancer, a patient in tremendous pain. The pain-killing properties of morphine have been known for well over 1,000 years. The Dr. Sir William Owsley once described it as God's own medicine. God's own medicine is available in India, but only in liquid form, a method of delivery that requires injections by trained personnel. Oral morphine, morphine in tablet form, the standard advocated by the World Health Organization. Oral morphine is illegal. Yet the government of India has recognized cancer pain as a problem and recently has allowed some experimental drug trials at selected demonstration sites. One such place is the Shanti Avedna Ashram in Bombay.
How much is another one on morphine?
30 milligrams twice a day.
He's on 60 MSD, 30 in the morning, 30 in the evening.
It is a hospice for cancer patients, the first of its kind in India. Its patients are poor and often without family. Dr. Luis de Souza, a surgeon at Tata Memorial, is the medical director.
I thought that the day we got oral morphine, that it was a milestone in our therapy here. As you can see, we've got at least out of 18 patients, a third of them on oral morphine. There's about 20 to 30% on oral morphine. Otherwise, you need more medication for your pain?
Even with a small supply of the drug, the results here have been dramatic. Proof that oral morphine can deliver relief from pain. But is a Western model of hospice care the way to deliver the drug to India's cancer patients? At full capacity, this gentle place will be the final home for up to 50 patients at a time.
It's okay. You're at peace. Good. Good show. I come to wish you for Easter. Good.
But numbers overwhelm in this country where every day hundreds of thousands have cancer and hundreds of thousands are in pain. Another demonstration site with a different approach to the problem of oral morphine and pain relief. The pain clinic of the Gujarat Cancer and Research Center in the northwest corner of India, the second largest teaching hospital in Asia.
But at present we give 5 milligram orally, so we will have to dissolve this morphine into water.
Yes, sir. Dr. M.T. Bhatia, an anesthesiologist and specialist in pain, supervises medical resident Dr. Sanjay Shah as he administers liquid morphine to Mrs. Jasudabin, who suffers from cervical cancer.
And she needs 2 days medicine, so...
By law, Bhatia cannot give his patient oral morphine. So he gives the law a little twist and prescribes liquid morphine, delivered not by a shot, but in a cup of tea. Injectable is made into oral morphine. And this couple can go home, the precious medicine gripped tightly in hand. There is no need for Mrs. Jasudabin to return to the hospital for injections. Instead, she can send her husband to replenish her supply, which he does 2 days later, and reports that his wife's pain is nearly gone.
It's a paradox that we don't have oral morphine in our country.
It is a paradox because India is the world's leading exporter of opium, the raw material from which morphine is manufactured. Intrigued by that paradox, Dr. Charles Cleland came to India in the spring of '88 to confer with Dr. Bhatia about opium and oral morphine and India's progress in cancer pain relief.
So I get a real sense that this is moving very quickly now. What do you think accounts for that?
The account is 86 conference.
Another connection, forged through conversation, through the exchange of information, through the common language of cancer pain.
Opium is grown here. Opium is cheap here. Opium is available in the villages of India.
Bhatia has repeatedly pressed the government to release oral morphine. In the meantime, as part of a demonstration project, Bhatia is using opium to treat cancer patients from villages.
So we give her 30 milligram opium every 4 hours.
Villagers like Mrs. Manabar Mali. Her case is a common one. She suffers from cervical cancer, which has been judged to be terminal. The family is poor and cannot afford the expense of trips to the city for care. Mrs. Mali is desperate. Better to die, she has told Dr. Bhatia, than to live like this.
She had radiation 1.5 years back. Her cancer was controlled. She went back to her village. And then 4 months back, the cancer recurred and spread to the surrounding tissues, and she started having pain.
Only 30 milligram.
Here at the clinic, the proper dosage to relieve that pain will be determined, and Mrs. Mali will be taught how to take her opium in tea.
Slowly.
As soon as her pain is relieved, they are keen to go back home.
These villagers cannot afford to stay in the city. They want to go back to their homes, to stay with their families. To continue treatment for these patients, Bhatia has devised a rural outreach program staffed by members of the pain clinic. The pain clinic comes to selected villages every 15 days. On this day, they have come to the village of Ode to assess pain and dispense drugs. Among the cancer patients is the mayor of Ode. He is given opium for his pain, a 15-day supply, enough to last until the next visit. And if for some reason, if the monsoons arrive or the road is blocked, opium has one very critical advantage.
So we prefer opium because patient can continue on the same treatment from the local sources.
It may seem like a long road, from the mayor with his prescription for opium, to the governor of Wisconsin signing a cancer pain proclamation, to the president of India inaugurating a new cancer pain clinic and teaching facility in Gujarat. But the word is getting out, and governments from Argentina to Zimbabwe have begun to listen.
2/3 in the developed countries and 3/4 in the developing countries are going to die of their disease, and pain relief is the major thing we can do there. Not prolong life, but improve considerably their quality of life.
The quality of their life, no matter the number of days. Some cancer patients will be cured. Many will not. For all of these patients, pain is needless, soul-destroying. Because we are, as Susan Sontag said, all citizens of the kingdom of the well and the kingdom of the sick. Because of this shared journey, surely we owe our fellow travelers this fundamental mercy, to provide them with relief from pain, to provide them with the medicine necessary to fulfill this prescription for compassion.